Alright, hello everyone. It is great to be back for another Wednesday. We of course missed out on last week, but that's okay, we'll make up for it this week. My name is Kane Treble, good to see you all, and tonight we are here to do some practice for our RACGP KFP exam. Hopefully your exam preparation is going well, your study's going well. Of course, we know that we have only a finite amount of time left before the next exam, but that's not to mean that we can't get lots done in this time. So, of course, let's have a look at what we have set up tonight. We've got a few things here, but as we start each week, we have 101 days left until the 2024.2 KFP exam. This might seem like a decent amount of time. You might be terrified because it seems like not a decent amount of time. Rest assured, this is actually plenty of time to get lots of practice in for questions to refine your technique. Again, the KFP exam is an exam that I think a lot of people muck up due to technique, not necessarily clinical knowledge, and so plenty of opportunities there. Now, I wanted to spend a little bit of time again. Wouldn't be Kane without the cough, I'm sorry. I want to spend a little bit of time going on again about overcoding. I know it's something I talk about time and time again, but it's for good reason. Overcoding, I think, is probably the thing that loses most people the most marks through the KFP exam. And it's something that, unless you realise what you're doing and how you're doing it, it's really, really easy to continue making that same mistake over and over. So let's have a look at ways in which we can prevent ourselves from overcoding. So I've got a little example here. This is one of the questions we've used previously. Lakshmi is a 55-year-old woman presenting to GP for routine checkup. No specific complaints, but mentions she's had a family history of bowel cancer. So this is a question that leads you into what is the appropriate screening recommendations for someone with bowel cancer, with a family history of bowel cancer at the age of 55. Now, hopefully you are up to date with the National Bowel Cancer screening requirements, and if we focus in on this question in particular, is what are the appropriate screening recommendations for this patient based on family history and age? Provide one recommendation. So remember, one recommendation, one answer, one line, 1 point. Now, that might be worth more than 1 point in actuality, but I want you to be focusing on that one specific answer for that question there. Now, of course, if we're going into this exam, we want to show how much knowledge we know, and the mistake I think a lot of people end up making is that they'll put an answer like this. So, fecal occult blood test every 2 years from age 40 to 49 years, with colonoscopy every 5 years from 50 to 74. This shows that you know the relevant guidelines. This shows that you know what you should be doing for this patient. What it doesn't show is that you know how to pass the KFP exam. If you were to write just colonoscopy every 5 years from 50 to 74, you'd get 2 marks. If you were to put down FOBT every 2 years from 40 to 49, yeah, you might get 1 mark because this patient's over that age bracket, so it's probably less relevant. But if you're actually putting in here FOB every 2 years from 40 to 49 with colonoscopy every 5 years, you have broken the rule of overcoding. You are giving too much information in that answer. And here's the scary thing, not only do you not get full marks for that question, you actively lose marks. And that's 0.25% of your total exam mark is subtracted for every instance of overcoding. Let's have a look at what that might mean. Here is a breakdown from the 2023.2 KFP exam report with the distribution of marks, candidate scores through that examination. So if we factor in the fact that each instance of overcoding is 0.25% from the overall exam score, let's do an example here where, say you happen to get 66%. Fantastic. Well done. You've passed, and you've passed well. That would probably get you a P2 or P3 exam result, and you'd be patting yourself in the back and everything's good. Let's pretend, in this example, that you have overcoded just once for each of the 26 cases. That means you would lose 6.5% of your overall exam mark, and that might actually bring you down to just a borderline pass mark. You are cutting it very close. And that's pretty easy to do by accident. Just once per case, I think there's a lot of people that would fall into that trap. What I suspect we see, though, is So we're probably doing it more than once per case. And if you're not really alert and paying attention and looking out for overcoding, it's possible to actually do it for every single question. So if we say on average, each case has 3 questions to it, and you overcode just once per question, you're actually going to lose 19.5% from your total mark, which would actually bring you down to a fail. Can you imagine how devastating that would be, knowing that you know the answers, but it's the exam technique that actually lets you down? This is why I think it's really important to focus in on this and make this something that you really pay attention to every time you're practicing an exam question. Let's have a look at some of the things you should be looking out for to tell, am I potentially overcoding? Because it is something that is particularly easy to do. We know the expression no ifs, ands or buts. We do it for our cognitive assessments. The fact that I had to stop and think for a moment, what do we use it for, is probably telling. But anytime you're using any of those kind of statements, with, and, because, as, anytime you're adding a comma, stop and ask yourself and catch yourself, am I overcoding in this instance? Because there's a decent chance you are, and those are marks you are unfortunately throwing away. Now, I want you to focus in on this tonight. I want you to make this the focus of your practice tonight, regardless of how you feel you do any of these questions. I think as long as you can say, well, I didn't overcode once, that's a massive step forward, and hopefully will get you over the line to passing this exam. Of course, we have a bunch of questions lined up. That is what a lot of you have come in here for. So I think we'll get 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at what some of those answers could be. Now, as we've expressed before, knowing what your DSM criteria are for meeting certain diagnoses is very much fair game in the exam. And as well, being able to apply those nuances, in particular things like timeframes, is incredibly invaluable, not only for making an appropriate diagnosis for your patient, but getting through these exams here, in particular KFP. Now, there's a couple of kind of generic things you'll always find in these mental health questions, and those are usually along the lines of, is there a family history of mental health disorder? We do know that there is potentially going to be ongoing mental health conditions that run through families, puts them at significantly increased risk. Is there a history of illicit drug use? Now, this one's also in particular importance simply for the fact that a lot of diagnoses require there to be no concurrent illicit drug use or no other kind of explanation along those lines that would preclude diagnosis. I think if you were to have something along the lines of here, experience delusions of grandeur, paranoia, or thought insertion or broadcasting, anything in that kind of bracket there, they would probably be grouped together. Of course, in the actual exam, I wouldn't be putting / / that would definitely fall into the realm of overcoding. But if you're having something in that kind of bucket, I think you'd be definitely getting a mark there. Again, we're coming into some of those time frames. Have these delusions been present continuously for the 2 months? So you're establishing time frames here, and it's the continuously that is not specifically stated in that history there. This can be particularly helpful for differentiating things like schizophrenia from schizoaffective disorder, for example. Now, of course, tying into that exact same thing as well is the symptoms of mood disorders being present for a majority of the active portions of illness. So again, this is one of the really important differentiators from things like schizophrenia and bipolar and schizoaffective disorder. Has there been a period of disturbance for at least 6 months? Again, one of the other diagnostic criteria. And has there been impact on her relationships? This is one that isn't DSM, but you'll always find this as one of the answers for RACGP questions. Hopefully that makes some sense. Now, of course, we have some excellent answers in here as well. And to be really, really nitpicky, because that's kind of the point of me being here, really, recreational drug use, fantastic. Low mood, I would actually be specifying in not just low mood, but time frames, because one of the things that has been brought up here is that it does specify, where is it, if I read through, she denies changes to her mood. And so that would be a little bit risky unless you're kind of specifying something in particular about that mood change there. Chronic headache isn't on this list, but actually I would include that an excellent pickup here, because that would also be excluding other causes of personality change. One, of course, would be intracranial abnormalities, intracranial lesions. Good, well done. Thinking outside the square, good. All right, let's get that one off there. And of course, there's follow-up questions here. So let's get another 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers here. And you will get questions like this where it kind of says, okay, pretend every other bit of information you get isn't actually that relevant. All those questions you've asked probably don't contribute too much here. What is going on? And you can see here, and I want you to kind of pull back the curtain a little bit, you can see they're really trying to shoehorn you down that kind of mental health pathway. And so often it can be good to follow that paved road, so to speak, and focus in your answers on that, particularly when you only have, say, 4 options here. Now, lots of things that this could be, and based on timeframes, based on mood changes around some of this hallucinations as well, I'd be putting high up on this list something like schizoaffective disorder. And with the information we have so far, it would be very difficult to actually tease this apart from something like schizophrenia, and probably a little less so along the lines of something like bipolar disorder with psychotic features. Now, this is one of those instances where being really specific, being really niche into showing your consultant level knowledge gives you those extra marks. So specifying with psychotic features is more likely to get your mark. I think if you just put bipolar disorder, you're probably not going to get those marks there because there's not quite enough specificity to that diagnosis. Likewise, this could be something like depressive disorder with psychotic features would get you a mark. I don't think personally that not having the psychotic features there would actually give you that diagnosis. Now, we do have a bunch of excellent answers coming through here. Let's step through what some of these could be. So, here we've got manic episode of bipolar, fantastic, and I really love, again, how specific you're being. Depressive episode with psychotic features, chef kiss. Space-occupying lesion, yes, yeah, I think that definitely could be in there. Not on this list, but again, as mentioned before, if there are headaches present there, it would be one of those things you would want to be further investigating. And schizophreniform disorder, yes, there's enough boxes being ticked here that I think that probably would be fair game. Good. Now we've got some more answers here of intracranial glioblastoma. Really good. And in particular here, not only have you been specific, you've been super specific of one particular form of intracranial lesion, which, again, fantastic work there. Depression with psychotic features, tick. Schizophreniform disorder, beautiful. Bipolar affective disorder, again, just to really kind of hammer it home, I really would try and put in with psychotic features just to add that specificity to it. Question here is, doesn't schizophrenia need more than 6 months? And the response is yes. But this is where you would try and tease out more information here, and it would be one of those ones that you would be wanting to further investigate. Here we have question 2 mentions, a question mentioned 2 months of delusions. Wouldn't that be too short for schizophrenia? Yes, so again, kind of factoring into that same one there. In this instance, I think schizoaffective disorder would be much more likely. What I would want to tease apart here is, have there been previous instances where there's also been some of these delusions, and what kind of time frame have they occurred over? This is tricky because they've specified in here that any further information obtained is non-contributory. And so you do have to have a little bit of kind of creative license in terms of, well, does that mean that they haven't been able to give you any kind of legible or sensible responses? And tying into that further history would probably tease out a little bit more. But yes, correct in terms of diagnostic criteria. I don't think I would definitively exclude schizophrenia. And the other kind of side to that coin is, maybe you actually just need to wait a bit longer until you tick that kind of 6-month mark, but that still would be managed as a schizophreniform type disorder or schizophrenia type disorder. Hopefully that makes sense. Okay, of course we've got a final aspect to this question here. Let's get 2 minutes back on the clock then, and your time starts now. time is up. Let's have a look at some answers here. And I'll preface this one by saying that this is probably not a question you're going to see in the actual exam. And I've intentionally not put down a list more than 3 here because this is going to be a state-specific thing. And so I think it would be probably a little bit unfair on the college to be asking in a national exam information that has so much state variability. I've got some of the answers here for Victoria, for example, but if this isn't something that you're particularly familiar with, I think it's actually really handy for you to actually look it up and have a good working knowledge of what is actually your state's criteria. Now, there are some common things shared amongst all of these, and of course, number one is the person has to have a mental illness or appears to have a mental illness. This is a really important little caveat that's thrown into pretty much every state's Mental Health Act, in order to make sure we're only actually using these powers on people that have mental health conditions. In Victoria, and again, this is one that is actually common amongst most states, is that the person appears to need immediate treatment to prevent serious deterioration in the person's mental or physical health. In Victoria, that is separated out as well into an additional aspect of requiring immediate treatment to prevent serious harm to the person or to another person. And this is something that often paramedics will have to use this criteria to bring someone in under a section if the person, say, putting themselves at danger, be it running through traffic or wielding weapon, things like that. The person can be assessed under an assessment order, and this is something that I think sometimes gets a little bit tricky because the patient may be acutely psychotic, they may be substance affected, and it's important to note that in that condition, if we believe that there is substances on board, they actually can't be assessed under a compulsory assessment order until they've had a period of observation, they've been stabilised and medically cleared to be able to have that assessment occur. Now, that doesn't mean that you can't actually place them under a assessment order requiring them to be brought in for psychiatric assessment. It just means that they can't actually have that assessment undertaken while they're substance affected. And of course, a really important one that really has been kind of hammered home in Victoria at least is that there is no less restrictive means reasonably available. Reasonably, what does reasonably mean? That could be argued. To enable the person to be assessed. This is actually a really powerful kind of addition to the Act that gives the patient a lot more control and autonomy to be able to say, I'm going to choose to do this voluntarily so that they don't have to have certain freedoms, certain liberties taken away from them. You might argue it's kind of semantics that, you know, if they don't agree, then they're going to be forced to agree. And in some regards, yes, that's true. But if you speak to patients that have been in these kinds of circumstances, I think it is incredibly empowering and humanising to still be given that opportunity to engage somewhat on your own terms. So again, if you haven't actually had the chance to read through your state-specific legislation around this, I strongly encourage you to do so. All right, probably time to move on to another case though. Now, if you are watching this, do make sure that if you kind of hover over the video, make sure that the little red marker is kind of as far over to the line as possible so that you're watching the video in as close to real time as possible. Sometimes YouTube loses sync a little bit, so just making sure you are watching this at the right time means I'm going to be able to more appropriately respond to any answers that get put through. Of course, we have case number 2, so let's get 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at the answers. And every now and then you get one of these questions where you're like, oh, beautiful. What an easy one. Quick answer and move on to the next one. These can be traps. And I wanted to just highlight this question here as a specific example. Now, the thing that's going to get you full marks for this one, and always remember, if there is just one response required, that response has probably got to be a good one. It's either going to be a very specific diagnosis, or, as we have here, it's going to be an answer that requires multiple parts. So the most appropriate answer here would be urgent transfer via ambulance to emergency department for suspected Addison's disease or adrenal crisis, something in that kind of ballpark. The thing that gives this the full marks here is you're specifying that it's urgent is the number one criteria. You're specifying where, so emergency, and you're specifying why for suspected Addison's disease or adrenal disease. Now, you could put anaphylaxis here. You could put something completely random, but I think as long as you're specifying a reason why you're concerned, I think that's going to get you some extra mark. I mean, if you say for a bee sting, they're probably not going to give that to you. But I think if you're making some kind of sensible, logical leap into the realm of why you're concerned, tick, 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 tick. Now, this is one of those instances where it's easy to lose marks here, because if you were to just specify urgent transfer via ambulance to ED, you've already lost 1 mark there. If you were to say transfer via ambulance to ED for suspected Addison's disease, there's a chance you might lose a mark because you haven't specified urgent transfer. I mean, you could argue there is perhaps a little bit of time to wait for this one. The blood pressure's low, but it's not terrible. There are inherent risks in terms of paramedics driving lights and sirens to and from emergencies. But again, it's really showing that specificity in your answer. Likewise, referral to ED for suspected Addison's disease, you've lost that urgency criteria, and referral to ED 1 mark, because yes, you're doing the right thing, but it's not showing that consultant level knowledge of why and how you're doing it. So I'm going to be super picky here, and fantastic response here. Urgent referral to the local emergency department for glucocorticosteroids. You've specified urgent, you've specified ED, you've specified why. You've kind of jumped ahead even, and this is something exams do, so feel free to do it yourself. This is showing the person that's marking the exam, not only do you know what is wrong with this patient, you know what they need to do about it. So that's actually a fantastic answer there. Urgent transferred ED, again, correct, but lacking a little bit of the specificity that consultant level knowledge requires. And so just kind of fleshing that out, and you've fallen for the trap, sorry. I'm glad you did, because this is one of the things I wanted to highlight with this question. Sorry to pick on you. All right, of course, there's more parts to this question. So let's get 2 minutes on the clock, and your time starts now. All right, time is up, and let's have a look at the answers here. Is it JGC? Is it HJG? Is it CHJ? Guess what? You're all fantastic. This is one of those things that sometimes will freak you out if you're seeing other people putting different answers down. Often there are going to be more correct answers than what they're asking for, and this is one of those classic situations here. And so again, you've already picked the diagnosis here with your previous answers in regards to this is Addison's disease. How are we going to confirm that? We're going to get a adrenocorticotropic hormone. We're going to get a serum cortisol, and tying into that as well is going to be our serum glucose and urea and electrolytes. Best bang for buck with those marks there. Well done, guys. No more needed. Let's move on to the next part. 2 minutes on the clock and your time starts now. Except it's a delay, so let's put 2 minutes on the clock and your time does. All right, time is up. Let's have a look at some of those answers. This is one of those questions that's going to potentially challenge some people if you're used to thinking more along the lines of just pharmacological management. And if you get caught in some of these situations, ask yourself, what would you actually do if this patient's in front of you? Because that's what's going to be what this patient actually needs. So for here, of course, we're going to need urgent referral to an endocrinologist for ongoing management. And again, this is one of those kind of three-part responses. You're saying this is an urgent referral. This is a patient needs to be seen pretty much immediately, who it's to, and what it's for as well. You can be as vague as saying ongoing management. You could continue resuscitation. You could say for management of Addison's disease, but specifying why you're doing something, again, is something that they really like to see as showing that consultant level knowledge. Now, some of the other non-pharmacological management things that are particularly important is to prepare your emergency or adrenal crisis management plans. These are things that save patients having to go to ED in the first place and is vitally important to do for any patient with Addison's disease or adrenal insufficiency. Now, this would be something that probably would be prepared in conjunction with their endocrinologist, but I think any GP worth their salt would also have a crack at putting something together to make sure the patient's as safe as possible. And if it's something that you haven't had much experience with before, there's actually some really, really good templates or kind of guidelines to follow on ETG. Tied into that as well is going to be preparing a sick day management plan. Now, this is different to an emergency management plan. Emergency management plans when they're going to adrenal crisis. Sick day plans if they become unwell, if they're having an operation or procedure done, how are we going to address the additional corticosteroid requirements around these? Of course, we also have things like a medical alert bracelet, something to flag to those around them that if they do go into crisis or get injured or become unconscious, there's a way to alert people that they have that condition there. And something that probably goes more into the long-term management of patients with newly diagnosed Addison's would be requesting a bone density scan to assess for baseline fracture risk. These are patients that are going to have significantly increased fracture risk, and so more aggressive management of bone density is definitely indicated here. Having a look here, tricky, yes. And this is, again, one of the challenges of these questions is often if the patient's in front of us, we know what we need to do, we do it. But putting that into words in an exam setting can be difficult. And so having these to practice on hopefully makes this easier for you. You've absolutely nailed it, though, in terms of urgent referral to endocrinology for advice on Addison's treatment. And you've gone into kind of more direct management of the patient, which I'll be honest is not incorrect. And I think if you were to put insert IV cannula, talk about rehydration, I think actually you'd probably get marks. And this is something, again, I'll highlight. It's actual doctors marking these exams. It's your peers marking these exams. And as much as they try and screen these exams, screen these questions, situations exactly like this come up every single year. And so if enough people have kind of done this same thing where you've kind of said, oh, well, this could be interpreted in perhaps a different way, they do actually go back, look at the answers provided, add new answers, and remark those that may have put down those similar kinds of answers as well. They then also reword the question to be more specific for use in subsequent exams or practice exams as well. So well done. Here, referral to endocrinologist for ongoing management, perfect. Referral to dietitian for high energy diet, high protein diet, yes, very, very good. Not on the list, but definitely would get you marks here. Testing for celiac disease, yes, there is also a very big association between Addison's disease and celiac disease. So again, getting good marks here. Advised to stand up slowly. Potentially. I think it's probably a risky question. Risky answer. I don't know if you would get marks, truth be told. Flu vaccination. This is one of those tricky ones because is a vaccination classed as pharmacological or non-pharmacological? Arguments can and have been made either way. Personally, I'd probably give you a mark. But it would probably be one that some people may not consider. They may say that's a pharmacological intervention and so may not. And so if you can think of other answers, I'd probably use those preferentially. Hopefully that makes sense. All right, we do have one final case here tonight. Now, you've probably noticed this is driving me absolutely bonkers. I've got new glasses. And I got the anti-reflective coating there, but you can see the reflection of the screen in my glasses. It's like I'm doing a Gendo Akari impersonation. I don't mean to, but it is driving me bonkers. I'm probably going to find my old glasses and I'll use that for future live streams, but I'm just trying to dodge the monitor at the moment. Sorry, that's just me entertaining myself for a minute. All right, final case for tonight. Thanks for your patience. Let us get 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at those answers. Everyone has their thing they don't like dealing with. And I know one of the things my wife does not like dealing with is feet and toes. So it gave me a little chuckle when I put this question together. Now, for those of you that haven't had much to do with toenails, I think the natural knee-jerk reaction here is to say, this is a fungal nail infection. But I want you to focus in on what is actually some of the things you'd be looking for to determine, is this a fungal nail infection? Is this perhaps something different? So what are the examination findings? Go back to first principles. Think, what am I actually going to see on these toes? Even looking at this picture, and sometimes looking at the pictures gives you that bit of a hint of what kind of things could you be examining for. And certainly that kind of crumbling, chalky, brittle nails, you can see that toenail there looks like it's very, very crumbly underneath. You can see all that keratin and dead skin cells trapped underneath the nail there, lifting it up, as well as the direct thickening. That would be something that I'd be looking at there. Now, it has been pointed out here, a lot of those are already visible in the pic. Yes and no. So, crumbling, chalky, brittle nails would be an examination finding. That nail, if you actually touch it, might be hard as a rock, or it might completely fall to dust the second you touch it. And so I think you could make that argument there that it is a new examination finding. Longitudinal streaks running from tip to base. I don't think you can clearly see that in this picture here. This is intentionally a bit of a kind of vague, semi-obscured, not very clear picture, and so I think would make it fair game, to be honest. Presence of flake wet patches on the nail. Yeah, you got me there. That one's on there, and you are correct. It does say further. Elevated from the nail bed. That one, I think you might get a hint of it here, but specifying exactly that you're looking for that, I think probably would still get you a mark. Malodor and offensive smell. If you have smell-o-vision, I feel sorry for you because this would not be a great time to find it out. But again, thinking about if you're in that room and that patient and that foot is in front of you, what kind of things might you notice? Scaling on the plantar, skin, or web spaces isn't clearly visible here, and that took me a little while to find a picture I was happy with. Intentionally not here, and so I think would be something you would specifically look for. You are correct, though, in terms of scaly erythema in the interdigital spaces. I really love that wording there, again, reflecting that consultant level knowledge. Psoriatic plaques on extensor surfaces, perfect. Unusual bold spots on scalp. Yes, if you're really going down that kind of psoriatic pathway, I think you certainly could put that down, and again reflects that kind of broader base of knowledge you're working from. Horizontal ridges in nails, yes, I think would get you marks there. Again, on this picture here, not very vague. You might actually get a little bit of a hint of it. Here we are, bring my mouse into view. A little hint of nail changes coming up along this nail here, but you would be specifically examining for all the rest of the nails as well. And yes, as you stated there, that would be alopecia areata. All right, now, there's of course more to this question. Where could this be going? Let's put 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at what some of those answers could be. And we have here a few things. Nail trauma, and this is traumatic onychosis, is something that I think probably gets missed more than it should. And we end up treating a lot of patients for what we say are fungal nails that actually don't have any response there. And sometimes it's frustrating, you're treating, you send off clippings, they never seem to grow anything. Remember that nail trauma can present very, very similarly to fungal nail infections. Of course, that is the other likely candidate here in terms of fungal nail infection or onychomycosis. Eczematous or psoriatic nail changes can present very similarly as well. You can also have nail changes related to things like renal disease. There's lots of other conditions, of course, that kind of factor into there as well. And I think if you're putting any of those kinds of things, you're probably going to get a mark. Renal disease was just one specific example here. And there is yellow nail syndrome as well, which, if you're not familiar with it, can present with yellow nails, surprise, surprise. The thing that leads against that here is that we only have 2 nails involved, whereas yellow nail disease, you would expect all nails to be involved. Now, we do have here right big toenail psoriasis, and yes, I think that probably would get you marked. If I wanted to be really nitpicky about it, I would actually say that this question points out that it actually started on the left big toenail and seemed to have jumped across to the right as well. And so you could probably say bilateral big toe psoriasis. And I think you'd probably be more guaranteed to get those marks there. But certainly if I was doing it, yeah, you got marks. Onycholysis of big toes, onychomycosis of big toes. Absolutely fantastic answers there. And again, I like that you're thinking of that kind of more trauma type activity here. So one of the things that is often frustrating for patients that have that kind of presentation is they say, oh, no, I don't remember, hurting my toe or damaging it at all. It can take up to 3 months for the injury to actually present in a clinical fashion with those nail changes. And often by that time point, the patient's forgotten that they actually stubbed their toe or dropped something on there, because it actually doesn't take a whole lot of trauma to cause permanent nail matrix damage that causes that thickening of the nail. With that, the nail can lift up off the nail bed. You end up with a whole bunch of skin and debris trapped under the nail, which gives it that kind of almost fungal-like appearance. So always remember, if you're setting off samples, no fungus is growing, ask yourself, could this actually be nail trauma? And try treating down that pathway, which really is more of a conservative type pathway. But excellent answers there. Happy to see them all. And I think in an exam, you'd absolutely crush that. Okay, we have part 3 here. Let's put 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers here. And I think some of the low-hanging fruit is, of course, going to be send that patient to a podiatrist. Now, again, this is specifying time frames, so regular, who it's referring to, podiatry, and what for nail care. I think putting that down is going to get you full marks here. Some of the other things that I think are really, really important to do is try and backtrack and work out what has perhaps caused this change to occur, because you want to prevent further nail trauma to other nails as well. So one of the common things, particularly if you're looking at bilateral big toes, is are they wearing pressure-inducing footwear? And so making sure they have wide footwear is incredibly important. If this is something that isn't responding well to regular podiatry, or they're really frustrated by it, really sick of catching on things, sick of the appearance, you can actually elect for surgical nail removal. So ring block, take that nail out, and there's a chance that the nail will grow back more normal. 99.999% of the time, though, it's just going to grow back and do the same. And so you can actually use phenolization or nail matrix ablation to destroy that nail matrix, and the patient can live a happy, full life without a toenail. Probably the more extreme example here, but every now and then you'll find a patient that's just so sick of it, they just say, look, let's just be done with it. Now, we do have some excellent answers here in terms of trim nails close to the skin. Yes, this can be helpful for trying to reduce it catching on things, particularly if a patient's prone to scratching themselves or trauma from there. It doesn't tend to help as much in terms of the debris caught under the nail, but as you've already put in, avoid using soap, avoid using irritants, and I like these specified as well, avoid nail water immersion. And so you do sometimes see these kinds of toenails in people that do lots of swimming or have lots of water-based exposure. Prolonged water exposure or nail immersion will soften the nail, cause it to swell. That can bring about things like cracks and fissures, and doing that repeatedly over and over can traumatize nails and lead to this kind of thickening process. So yeah, not in the matrix, not in the answer matrix here, but definitely I think anyone that knows anything about nails would be giving you marks for those responses there. Well done. All right. Well done. That's our 3 cases done for tonight. Some awesome responses there. Really good to see engagement here. I'm going to be continuing these live streams ongoing as well before the exams. So set alarms, spread the word, tell people about it. The more engagement we have, the more people I see joining these things tell me that it's worthwhile. I'm not wasting my time, and that lets me know I need to keep doing them. Now, if you've got a couple of minutes free, I wouldn't mind just pop into the chat kind of where you are geographically, where you are in terms of exam preparation, when you're hoping to sit the KFP, if it is the 2024.2, or if perhaps you're waiting till next exam to sit. And as well, if there's particular areas you would like me to focus in, because I can kind of try and customise questions for those that are attending and participating, and to make sure you're getting the most out of this that I can provide. So feel free to throw some stuff into the chat there. Again, to kind of give you a little background, I have perhaps somewhat unique experience with dealing with the KFP. I've actually sat it 3 times before I passed on that 3rd attempt there. Admittedly, the first time I sat, life was not great. I had some significant life issues and significant illness in the family that really eroded all of my study ability. And so I definitely was not prepared when I first sat. Did not do well, wasn't surprised. When I sat the second time, slightly better headspace, had a bit more time to prepare, but I think I was falling into those traps, and when I went back and kind of reflected on all of my previous answers, overcoding was my trap. And so for my 3rd attempt, I really focused in on my exam technique, didn't study anything extra, and absolutely smashed the exam. So that's why I'm keen to try and generate as many practice questions as I can, because I think the more you practice the question, the more you practice your technique and catch when you're actually making those little traps, or falling for those traps, I think that's when you're going to make sure you have the best chance possible of passing. So, Demir, always good to have you here, mate. And from Albany, Western Australia, so good to see people all the way from the west there. I've got one of my brothers actually lives in WA. Love the place. Try to visit him when I can. I'm in Mildura, so relatively similar climate to where you are. I don't know how people live with the cold. And Jenna, sitting in July, cardiology for you. Yeah, cool. Okay, we can definitely throw some extra cardiology questions in there. And there is usually a couple of questions related to cardiology in the exams, whether it be ECGs or management of conditions like CCF. One thing that actually, I don't know why, RACGP really love, what are the side effects and complications of using things like ACE inhibitors or ARBs? So we might sprinkle in some of those questions in through here as well. And absolutely love Gippsland. I actually did my medical degree in Gippsland, working through Tralgan, Bairnsdale, Orbost for a year. Orbost was a fantastic experience in a very small town, but really loved it. Very cold though. It used to be I could go camping in the Alpines there and be in the snow, be really, really happy with it. And after a couple of years in Mildura, where it's 30 to 40 degrees all through summer, I can't do cold anymore. I've become soft. I've become a sook. Excellent. Okay. Look, I'll try and tailor some of my questions into those areas then. I think that the fact that you're turning up here for these kinds of live streams is fantastic. It says that you're on the right track as well. I think everyone's going to be absolutely brilliant for this upcoming exam. I won't hold you up any more than that. So again, thank you so much for coming in, offering your time, offering your feedback, participating. It really makes it rewarding for me. But it's probably time to go to bed. So I'll catch you guys next week. See you then. Spread the word. And until then, see you, Space Cowboy.